much, Prof. Allen. Great talk. So to be fair, let's start with the last. So I will start first question for Dr. Allen. So we have potential targeted therapy for LCH, MEK inhibitor and BRAF inhibitors. So can we extrapolate from what we are doing now in leukemia and other malignancies in bringing those targeted therapy to the backbone and fit it somewhere in the standard chemotherapy for LCH? Do you think that will improve the outcome for high-risk patients? And the other question also, have we tried using a combination of MEK as well as BRAF inhibitors clinically in clinical trial?
So those are excellent questions, and I think it's really what the field is wrestling with right now is how best to use these agents. Have extraordinary response rates, but it's not a durable response. There's some toxicity associated with being on these therapies, and so some in the field are putting their patients on these inhibitors and just keeping them on them kind of ongoing. I think your question about how to incorporate them into other strategies is an excellent one. I think now that we're starting to get some outcome data from LCH as well as some safety data from other pediatric indications, there'll be a move to move these inhibitors earlier to get a better response, but then try to figure out how can we cure these patients either along with the inhibitors or following inhibitor therapy. So that's one of the things we're trying to incorporate into the NACHO cobimetinib trial. And then also LCH has just been taken on by the Children's Oncology Group. It's one of the diseases that they recognize. And so hopefully we'll have an LCH trial coming out in Children's Oncology Group. And clinical trials are clearly the place we have to ask these questions. But like a lot of other kind of rare diseases, now we have this issue of so many different therapies to try. How do you prioritize those? Which agents within classes, et cetera, is something that I think we just need to be strategic about. But yes, I think to your point that this definitely is something that needs to happen, is to figure out how to best use these inhibitors and in combination with what other therapies. There hasn't been a lot of use of them combined, and I think one of the issues around LCH that's different than other conditions is that, again, these mutations are one or two mutations that drive the disease. When you look at melanoma, colon cancer, other BRAF V600E diseases, that's one mutation of hundreds of mutations. And so I think there's probably a different risk profile as well as a different efficacy profile for what I would say one or minor mutation disease versus heavy mutation disease. And I think probably most analogous to LCH would be looking at like low-grade glioma or neurofibromatosis, for examples, rather than looking at much more highly mutated diseases.
Okay, thank you. Another question in the same line. Do you think there is a place for targeted therapy in high-risk LCH patient who underwent stem cell transplantation, post-stem cell transplantation in the future, do you think?
So if there, hopefully no LCH patients will have to get transplanted in the future. I think that LCH should be controllable in almost all cases. Unless, there are some cases where it looks like LCH, but it's really a much more complex biology like histiocytic sarcoma or LCH that arises in the setting of leukemia. I think that's really more of a biophenotypic leukemia. And so those cases may have to go to transplant. In those cases, I think blockade may be helpful, but hopefully when someone's transplanted, they no longer have the clone. But I think in this modern era of MAP kinase inhibitors, we should not have to transplant patients with LCH.
I got a question here in the chat box. The role of PET scan in monitoring remission in LCH. That's
an excellent question. I think that we're learning with LCH, like other lymphomas, that PET scan is critical, especially when we're using the MAP kinase inhibitors, because disease resolution can take a while, especially with these bone lesions, right, where you have tissue destruction. It's hard to kind of tell the difference between the lesion activity and a normal healing tissue. And so I think, as was evidenced by that one slide where I showed using strict RECIST criteria, there's only 43% response rates to vemurafenib, and it was 100% response rates when you look at a metabolic response. I think PET is probably the best disease to establish extent of disease when patients present with LCH. It's really the most sensitive and specific modality. With the exception of brain lesions, you really need to use MRI for those.
Yeah, you have mentioned that CNS involvement or LCH CNS improved in certain patients treated with targeted therapy. So that means, does it cross blood-brain barrier?
So that's a good question. I think most of the MAP kinase inhibitors that are on the market right now are not great blood-brain barrier blockers, but we use them for low-grade gliomas and other tumors, and I think enough gets in that it has effect. And also with the model of LCH, I think these are really, again, it requires a supply of blood cell-derived precursors to be able to cause the disease. So I think it at least blocks the differentiation of those cells.
Thank you so much. I have a couple of questions for Dr. Jeffrey and Dr. Turki. Let's start with Dr. Saeed Turki. What do you think first of all, do you know that we have national tissue banking and DNA banking? Is Dr. Turki with us? Yes, okay.
I believe there is a national biobank, I think at King Abdullah International Research Medical Center, which has a huge infrastructure accommodating millions or hundreds of thousands of samples. I think they launched the efforts to collect the samples with the phenotype and also provide multi-omics approach for those samples for researcher and physician to study various of diseases. But it's a huge effort, and it will require probably a few years to collect enough samples and make it available. But definitely there is multiple efforts in that regard. And since you use the national, I think that it was the national program as far as I know.
But do you have a system right now they started to collect from all hospitals, or there is a plan to do that?
I'm not in a position to speak on their behalf, but I believe they started with 5 tertiary hospitals that's under the National Guard Hospital in different cities. And I think the policies are under the way to be accepting samples from other places. I know also in King Saud University, there is some efforts into establishing their own internal biobank in a similar fashion, but probably this will be limited to the university hospital itself. And I'm sure King Faisal and other universities are having similar approaches.
From your experience, do you think that tumor profiling, genomic profiling of cancer in our area here differ than what is in the West? We know that certain genetic diseases here due to consanguinity and other factors, but what about the tumors?
You mean the somatic testing?
Yes, for target, for example, looking for therapeutic targets in the future.
Right. So I think I can speak on the solid tumors more, since my work is more focused on the solid tumors. And definitely, at least in lung cancer, for example, the frequency of mutation is different. Let's say, for example, in EGFR, in lung cancer adenocarcinoma, it's around 15% in Western populations, and in Southeast Asians, it's up to 30%, while in Saudi Arabia, it's between 20 and 25. So it's a little bit more than the European, less than the Asians. ALK fusions, for example, it used to be 7% previously. Now we are seeing up to 10% because NGS is detecting more cryptic, rare forms of these fusions. So I believe with more data, I think we will see a different spectrum, not necessarily a completely new pathways, but definitely we will have our own founding mutations, different hotspot mutation. There is a nice study, if we are discussing also germline mutation, from Dr. Moussa Zahran in King Saud University, where they published a specific variants, only common mostly in Saudi population and the Gulf countries, not anyone else, the 106, which is now, we pick it more than the usual in the European. So definitely with more sequencing and accessibility for these services, we will see a different spectrum. But this is also true for any population, especially the more homogeneous population, let's say.
Okay, thank you so much. I have a couple of questions for Dr. Al-Jifri. Dr. Al-Jifri, that we usually send molecular panel, bone marrow failure molecular panel, and sometimes we have negative result. So usually we are sending WIS, and sometimes we have certain mutations that it's new for us, really. So what do you think really the best from the start, rather than do it in 2 times? And do you think to send WIS from the start, and especially for also screening the donors?
I think I understand what you mean, because we sometimes get negative results. Not to say that some of the diseases are it comes negative, but I think the best source maybe to get a fibroblast DNA to study. That will give you an accurate, because the bone marrow, maybe Dr. Turki can correct me, the bone marrow has tendency, or the blood has tendency to correct itself, but the best sample is the fibroblast to get an accurate diagnosis. WIS is an important step to do it. I think nowadays in our hospital we're getting more accurate result. That used to be reported negative when we send it to another lab outside. So I think if you have high suspicion, I would go for buccal mucosa, for example, either chromosomal breakage or DNA studies for these patients.
Okay. In terms of the graft failure for Fanconi patients post stem cell transplantation, how do you condition them usually for the second transplant?
That's a very difficult question to answer, especially if you have used, you cannot go beyond reduced intensity conditioning. I would include the TBI, small fraction of TBI, 200 centigrade, to the fludarabine and ATG, if it's not used. But I don't think you can go higher, otherwise the toxicity will be more.
I have a question here regarding the frequency of hemorrhagic cystitis in Fanconi anemia post Hablo. Especially we are using Thiotepa in Hablo.
Right. It is. I mean, the toxicity of the conditioning is expected, especially hemorrhagic cystitis. Now, hemorrhagic cystitis, you need to look also for possibility of BK or adenovirus that is known in the haplo post haplo. But this is something that you need to monitor, and many of the patients, they develop this toxicity. And you cannot. I don't think if you skip the Cytoxan, then you're compromising your graft. In fact, in our experience, those who had Cytoxan 90 milligram with ATG have excellent survival, excellent engraftment and survival, better than the 20 milligram. So I think Cytoxan is an essential part, at least for this.
Okay, thank you so much, Dr. Al-Jifri. And really, we are late today, but I would like really to conclude this session by thanking all the speaker for outstanding talk, and really we have enjoyed it. So thank you so much. Also, I would like to thank the audience for being with us till this time. Many thanks to SSBD for organizing such interesting and congress. I would like to thank the scientific community